Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can thrive and be profitable and successful for years to come. The NSCHBC is a proactive organization with over 300 members, including legacy members, that share their wealth of knowledge and expertise with each other in all fields of the business of healthcare. For this episode, I'm happy to welcome fellow healthcare consultant and friend, Betty Hovey. You might know Betty from her LinkedIn post for Friday Fraudsters on OIG releases. She's also the owner of Compliant Healthcare Solutions, and Betty is an educator for coders, managers, health plans, administrators, physicians, and non-physician practitioners all across the country. She has also co-written manuals on ICD-10-CM, ICD-10-PCS, and CPT specialty areas. And an exciting alert, she also has a new book out called Harnessing Artificial Intelligence, AI, for Healthcare Practices Success, a Practical Guide. And that's just been released, and you can find it on Amazon or wherever you purchase your books. So I'm excited to have her today. Betty, welcome to the Edge Podcast.
Hey, thanks, Terry, for inviting me. I'm always happy to speak with you about any subject.
Yeah, and Betty also has her own live actual podcast. What's it called? I missed that one.
Healthcare Happenings.
Healthcare Happenings. Yeah, I always seem to miss it because of the time zone. I'm in California, and where are you located?
In Florida.
In Florida. Oh, yeah, big time. We've got that 3-hour time. I think one time you were starting at 4 o'clock my time. I'm like, I love you, Betty, but yeah. 4 a.m. is just a little early, but I hear it's great. And when I do get to log in and check it out, it's a really great forum. So I appreciate you for that.
Thank you.
So we have an interesting topic today, and I had to pivot because we had a different topic here. It was actually on non-competes, but we know that that's been enjoined now by the Attorney General of Texas. So now that's kind of on the back burner for a while. We don't know what they're going to do with that. So Betty and I are going to have a conversation about hiring NPPs, which are non-physician practitioners, or what AMA CPT likes to call them, qualified healthcare professionals, or QHPs, in a medical practice. And not just hiring them, but understanding their role in a medical or specialty practice, because Betty, I'm sure you can attribute this or confirm with me what I deal with when we both, because I know we both audit on occasion, and I know I audit a lot, is that we have some non-compliance going on. It seems like all the time.
Yeah, just a little.
Just a little bit, especially, and we're not picking on NPPs. We're just saying that within a provider's practice, and I know some physicians don't like to be called a provider, but I use that term lovingly as anyone who can bill independently for services. Sometimes we get complacent with compliance, and first, we have to really look at, do you need an NPP? Do you need someone that, and again, these are high salaried professionals, and does your patient population warrant a non-physician practitioner? And one of the things that I think I find, it seems like I find it all the time, and I try to talk to doctors about this, is that they hire a mix, NPs, PAs, and RNs, which, okay, that's fine, that's your choice, and we know RNs are on the lower end of the salary schedule. But Betty, I find that sometimes they try to interchange an RN with an NP, and now we're on a slippery slope of compliance and fraud.
Yeah, I do a lot where I've had practices when I've gone in, clients have told me, oh, well, they're the nurses is the same as an NPP, or, I use them when, find out that they're doing all sorts of roles when the physician is away and not providing that direct supervision, which is, as you well know, is a big no-no, when they're trying to bill out for all these services that the RNs are doing. So I think sometimes the practices look at the RNs as like the biggest bang for their buck, because they're, as you said, on the lower end of the pay scale when you compare them to NPs and PAs, but then you can't utilize them the same way in the practice that you can an NP or a PA. And I think a lot of times practices kind of seem to forget that, whether it be accidentally or on purpose.
Yeah, and it's kind of scary actually because when you do hear some whistleblowers, you know who whistleblows when doctors do that? The NPs. They're like, I went to school for a lot of years. I did a specialty kind of residency that they do. And, NPs are what they call mid-level providers, just like PAs. RNs are not. They
Right.
are, with a lack of better way to say it. And I can say this because I call myself a former RN. I still keep up my license, but I haven't practiced in 20 years. I keep up my license because I worked hard for that.
Yes.
But I don't still practice. But the one thing I notice is that, you're kind of a glorified medical assistant a little bit. You're above that, obviously, but you are not a nurse practitioner, and you have to be careful. And for those of you that, I know I've got administrators, coders, even physicians. If you got a CPT book, just look at page 5, and it talks about when using advanced practice nurses, APPs or physician assistants, QHPs, whatever you want to call them. It says that to be considered this qualified healthcare professional, that's an individual who is qualified by education, training, licensure, and within their scope, they can independently report their services, and that's the key. So if they can independently report an E&M service or independently report a same or similar service as a physician, then and you may have that NPP qualification or QHP, but RNs can't go past a level 1 nurse visit, I'm air quoting. And, as you know, that has to be under the direct supervision of either a physician or a QHP.
Right.
So one of the things that I think is really tough is when the RN comes in or the NP comes in and the doctor says, or even the medical assistant comes in, because sometimes NPP can mean any non-physician practitioner, not just the QHPs. And they'll say, this is my nurse. And a couple times, I've even my doctor, I'll go and I know it's the medical assistant. I'm like, are you really a nurse? She goes, no, they just call me that. I'm like, so you play one on TV or you stayed at a Holiday Inn Express. I'm like, she goes, I hate it when they do that because then people are like, oh, well, she goes, they want to unload on you. She goes, and I am very limited on what I can do. Have you run into that?
Yes, I think sometimes in practices uh, they don't, I don't think that they mean to be like intentionally deceptive. I think that just sometimes the naming and what they're calling people, they kind of feel interchangeably with different things. But I think it can be hard for then the patients when they do query or somebody is more, specific to what they actually are, then the patients start to feel kind of like, well, hey, what's going on here?
Yeah.
So it's very hard, but I do see that a lot where they kind of misname each other in the practice.
Well, I was talking to our good friend, Christine Hall,
Mm.
and she was telling me that she went for physical therapy for her shoulder and her hand. And there is a physical therapist that has a doctorate of physical therapy, and that on her, or his or her white, I think it was her white coat, it says Dr. So and so.
Oh,
I know. And she's like, no, no, no. Because can you imagine? I mean, not to mention a certain, government official's wife who tries to put that out there, but I
mm.
just, I don't like people using, if you're an academic, let's say you have a doctorate in education, then use it if you teach it as at a university, but to use it and make the assumption that you're a physician in a clinical setting, it to me is
Yes.
dangerous.
Yes.
I
Again,
mean,
I think it goes back to that trust thing too. When patients find out if that's what you're calling yourself and they find out that you're a PA or an NP or a whatever with a doctorate, then they're kind of like, yeah, but that, a patient looking at it from a medical standpoint is like, but that's not a doctor. So I think that, and once you lose patients, the
trust.
way that they feel about you and their trust,
Yeah.
then it's like, well, I don't know, should they be giving me a medication? Should I take that advice from them? It just calls in a lot of things into question. from doing those types of things. But I know the whole doctor, quote unquote, issue is kind of big with some of the NPs and the PAs, and they've had, I've seen news stories, in fact, about it, where they've got the placards on the door, to their
I
offices that
know.
say they're Dr. So and so.
Oh, it's
So
terrible.
it's a big, but I would tell my clients, just please, stick away from it, kind of take your own hubris kind of out of this and think of it from the patient's perspective. And when they're coming in, they're thinking MD doctor,
Yeah.
period.
MD
They're
or
not
DO,
thinking about those
exactly.
other things.
Right, and that's one thing. It's hard in California because this was actually it's a legal position here now, where we have a lot of PhD type medical professionals, but again, they're not MDs or DOs. But the assumption that patients are making when they put on them that I'm Doctor So and So, it's tough because one of the biggest things here, and I actually had a doctor inquiry about this, and I was like, oh no, faceplant. They have a nutritionist that has a doctorate in nutrition and health. And I'm like, well, good for you. You really took it up there. But again, you're not a physician. And the doctor asked me, he goes, well, so, oh, I think your head's gonna explode here, Betty. But he said, he goes, so Terry, he's part of my membership for questions. And he goes, so Terry, I have a question. He says, my nutritionist is, we just hired, is billing for virtual E&M services.
Oh.
I know. I'm like, my stomach dropped when he said that. He goes, but we're getting denials and I'm not sure why. And I'm like, oh, shoot. So then I had to basically say, okay, let's start at square one. First of all, nutritionists do not have E&M independent services in their licensure. Secondly, it's either diabetic counseling or medical nutritional therapy, again, for diabetes or chronic kidney disease, as you know, or transplant. I'm like, there's specific services. And again, they have to be under physician supervision. I go, but E&M is not one of them, and they're not physicians. He's like, uh-oh. I'm like, yeah. And then he tried to said, well, we were trying to also bill for what was it? Preventative counseling visit. I'm like, those aren't even on the telehealth list. I knew your head was going to explode. I can hear you. And
It
so,
just keeps getting better.
well, and for our listeners, we're not laughing like this is funny. We're laughing like you've got to be kidding me.
Yeah.
So, and we're both kind of just in a state of wow, before you hire a really expensive clinician like an NPPA, which
Yes.
can be appropriate, definitely, because we need our mid levels. We do. I love having a nurse practitioner or PA in certain, especially primary care or cardiology or specialty offices. But before you hire other non-physician practitioners that are not of that level, and, I asked the doctor, who told you you could do that? He's like, a coder on Facebook. I'm like, oh, shoot. So, you have to do your own due diligence. You have to look under the licensure and what they're
Yes.
allowed to do. And you and I know, just because Medicare says you can do it, your state may
Mhm.
say you can't.
Exactly.
Florida
Yeah.
comes to mind for me. You guys have a really interesting rules out there, especially
Yes, we do.
supervision. So oh man, it just kept getting better. And I'm like, I can never retire. Never,
No,
ever,
no.
ever.
Yes.
So, and I was citing the doctor is like, can you cite all this? I go, oh yeah, oh yeah.
Mhm.
So I had to send him like 4 different sites of, where this is not appropriate. And he's like, okay.
Mhm.
So
Well,
next question.
and that's the thing. I think sometimes before a practice jumps into some new service or some big kind of expenditure for something, or like bringing on a nutritionist, a doctorate level nutritionist or whatever they're doing, if you're spending that kind of outlay because you think you're going to get a nice kick in the practice for it, take that extra small time to consult with a healthcare consultant
Right.
that can kind of say yes or no, rather than, oh, well, Dr. Joe down the street says he does this all the time. Well, you don't know if Dr. Joe's actually getting paid for it, or if Dr. Joe is getting audited for those practices right now. I mean, the due diligence, like you said, it's just huge. It doesn't have to be something that's, if you're spending that kind of money, take the time to spend a little bit more to get a healthcare consultant that's knowledgeable in that field area to say, yes, you can do this because here are all the cited quotations, like you did for that gentleman,
Right.
or no, you
Exactly.
can't
Or
because
no, you
here's
can't. Right.
decided things. It's
Right.
just saves you a lot of headache when you have to hire a consultant at the other end when you're getting ADR requests for medical records and you're getting audited. That's going to be a little bit more expensive.
Right. And what Betty's referring to is that additional documentation request that is from an inquiry that can lead to an audit, that can lead to a payback, and the domino effect is just crazy.
Yep.
And, one of the things that, and we kind of brought this up, I'm in California, Betty's in Florida, so we have opposite ends of the spectrum in the country and completely different state rules when it comes to non-physician providers as well. So when in Florida, and correct me if I'm wrong, I think Christine told me this because I know she's in Florida too.
Mm.
When your rules say supervision, they mean physician. In our rules, they mean physician or NP or PA in most circumstances.
Yes, that's correct.
Yeah, so you're a little tighter or just a little bit more strict on certain rules. And in California, they're like, hey, almost anybody can do anything. So when people say, oh boy, you guys are laid back in California, I'm like, yes, even
Yeah.
healthcare is on a surfboard sometimes. I read some of these rules and I'm like, oh man, my head hurts from face planting. I'm just like, oh shoot. But the other thing, that just came into mind, and I was thinking about this when I was ordering your book today.
Thank
Do
you.
you, yeah, oh, I'm so excited because I love to hear you speak. I like how you word things. I really like what you bring to the healthcare community. What what are your thoughts as far as the mid-level providers and physicians hiring, or do you think it's going to hinder with the new AI, I guess, help tools that are out there? It scares me because I
Yeah.
think it doesn't have enough oversight or safeguards yet.
Yeah.
But I think there are ways that you can incorporate it where it is safe and as long as you use common sense, of course. And of course everybody uses that. Um, but
Or
do you
well, Terry, we wouldn't have jobs if everybody used that.
yeah, this is true. Okay, you got me on that one. But do you think it'll make an impact on, the nurse practitioner and PA that we need on the, population health, or do you think that it really won't have an effect?
I think for the and again I try like you do. I used to use the term providers all the time, and yes, I have seen many a physician who does not like that. So I try
I
to
know.
now say all the time physicians and APPs, blah blah blah, but when it comes down to the clinicians, the people that are providing the medical services to the patient, no matter what level they're at, I don't think it's going to affect how many of those you need or see in a practice. I think it's going to help when used correctly, because just like anything else, like an EHR, it's a tool. So if used correctly, it can help with things like the whole, physician burnout aspect and that kind of stuff, to where it's helping with their documentation burden of what they're doing, because they have some software that, does the scribing. So you can take maybe the scribe levels, out and use the tools, for things like that, to where, of course, the physician or APP that did the service always has to then go back and read it. And that's the side that, you and I really hit on, is it can make a pretty note for you, but it doesn't mean that that's right or that's what actually happened. You still need to go through it, just like those old days when they used to transcription and they would use that stamp that said
Oh,
signed but
right.
not read,
Yeah,
you know.
yeah.
So are they going to have one now where they'll say signed, but I
Not
didn't pay
reviewed.
attention to
Yeah.
what the AI did?
Right. Yeah,
So
prosecuting attorneys love that, by the way. They're like, do it,
yes.
do it. Yeah, put that stamp on there. Yeah.
Yes, but it's a tool. It can be very helpful with, patient callback and scheduling. And there's just many aspects in a practice where AI can be helpful. But I think it's to help the practice be more efficient and give better patient care, not necessarily, decrease the number of people we have, and providing, especially providing care to patients. I think with what we've seen in the numbers, just the number of doctors coming in and the numbers retiring, and we're going to have a problem
Yeah.
in a few years with having enough providers of service for patients, as it is. So we need to really help them become more efficient and to do their jobs better so that they can concentrate on the patients and do what they need to do, which I think is why the NPs and the PAs, why that's so good to have them in the practice to where they can help follow. One of the biggest complaints I hear from people, from the physicians and the DOs a lot of times is, they're in and out and, really fast, and they can't listen to me, and I don't have time to tell them everything. And then they'll get an NP or a PA in there. Usually the NPs more because they do have that nursing, heavier nursing background in them, where they really spend that extra time with the patient and listen to them and pick up on things. And they really get that better, closeness, so to speak, with the patients, than what we hear sometimes that the physicians can do. So I think with the NPs and the PAs, having them, do when you have a large practice that has a lot of routine visits and chronic disease management and, maybe underserved populations, I think they're a fantastic fit for that kind of stuff. And I don't think that that's going to go away.
That's good. Yeah, one of the things, and you've kind of hit it on the head there, to our listeners, before you set out to, if you're thinking about hiring a mid-level provider, they can do quite a bit of what the physician does. There's an incident
Yes.
to rule that's just Medicare, talking about, what your reimbursement is, which is exactly the same as physician as long as you follow the rules. I don't like it actually, but there's also, an 85% if they're billing direct, which they can. But the
Mm-hmm.
thing with NPs and PAs that you also want to be cognitive of is that look at your patient population for everything. Make sure that if you have a certain ethnic group, let's say in California we have very heavy Vietnamese and Hispanic. So do you have somebody that speaks their language? I know that deep down in San Diego, they have a very heavy, actually Russian patient population. And so I know that was one of my practices down there. He's like, I think I'm going to hire, I have actually a nurse practitioner who's Russian and speaks. I'm like, that's fantastic. So they were able to
Yeah.
bring in, CCM and care management, actually doing it from the practice, which I thought, wow, because patients they really want somebody that like you said, wants to can listen to them, can speak to them in their language, looks like them.
Yeah.
Actually, the funny story, there was this, I walked into this practice, they wanted me to shadow them. And it was in a kind of, I don't want to say in a seedy part of town, but okay, let's just say that in Los Angeles. And I walked in, and the PA and the nurse practitioner, actually both male, were scared the heck out of me. Okay. And this is just, I feel bad saying that, but they had tattoos everywhere and the skull on the neck and nicest guys you'd ever meet, but the scariest looking guys ever. And he could tell right when I saw him that I was backing up. And he's like, it's okay. And I'm like, he goes, I trust me. He goes, I was only in prison for 10 years. And he started laughing. And I'm like, yeah, you're funny. And he goes, I try to get people with that. But then, he said, but if you look around our patient population, and everyone's entitled, who's legally here to healthcare,
Yep.
regardless of what you look like. He was like, but look at our patient population, very heavily tattooed, very heavily, they just look different. I'm going to say that in that area of town. And he goes, and they come here and feel comfortable. And I'm just like, that's great. I said, and I don't think about those things, as far as you've got those. Well, I do actually. You've got patient populations of, different not just, ethnicity, but, you have certain populations of, and I'm going to say tattoo artists maybe, or,
Hmm.
the LGB community, or, just whatever. And you really have to speak to those populations, because everyone, again, who's here legally is entitled to that health care. And I think it's important to think about that when it comes to hiring practices for your extenders. First of all, can your practice afford it? Secondly, how
Hmm.
are you going to use them? I
Yeah.
see some people, I have a practice that the doctors don't trust their NPs. They're like, no, I go in after they're there. I'm like, why? If you're going in, to follow up on every single patient, that's a really expensive helper.
Yes.
So
Yeah. Yeah. That kind of defeats the point
it
of
does.
having
It
them.
defeats
Yeah.
the purpose. Yeah, that's an RN. That's a medical assistant,
Yes.
LVN, LPN. Yeah, that's not a PA or nurse practitioner. And and it's hard to kind of get them into that mode. Just going back to the thing we were talking about, as far as calling them doctor, calling them, what they are. In California, there's this big thing right now where, and I think it's also with the National PA Society or whatever, they want to change PA, and it didn't. They said so far legally they can't, but it's coming. They're trying to get it to come anyway, from physician assistant to physician associate.
Yes. I saw that. Yes.
And Betty, I don't like it because it reminds me of attorneys. An
Yeah.
associate is a fellow attorney.
Yeah. And I don't, something like that too. They've been, a PA, and they use, they'll just use the letters and say PA instead. But patients and people in the field have always called them physician assistants. I don't think, changing, what they try to call themselves is, they should have chosen a different name back then, when they started. You should have, picked your name and what you were going with. I don't think, it doesn't change what they're doing. And I can see where they're coming from, but I think it's a little late in the game to kind of be picky about, what somebody's calling you.
I
I don't
agree.
know.
Yeah, no, I agree. I think once you start going down that slippery slope, to me, kind of like, and again, you have a doctorate. You're not a medical doctor. There's a difference
Right.
when you get that PhD, and you have to be careful of what you infer, what patients think. And I have seen some PAs that, put Dr. Bobby on their white coat, and I'm like, no,
Mm,
you're not. You can't do that. And
yeah.
one doctor told me, he goes, well, patients are more comfortable if they do. I'm like, yeah, but it's wrong. You can't do that.
Yeah, again, and what happens when the patient, finds that what you actually are, which is perfectly fine, you can still treat the patient,
Yeah,
then they feel deceived.
they do. They do.
And that just can just break the trust, wreck the I just, yeah, I definitely say that's a no-no.
Well, there was an OIG post, and I don't know if you saw it, because I know you just get those like I do, that said that they were they tried, there was a, not a fraud situation, but there was a pretty much a compliance situation that they're going to have to pay back money. And there was an intent there, and that's what happened. It was a couple of PAs that were saying that they were physicians, so the complaint actually had them as physicians, and then they find out they're not, and then they expanded their look. They're just like,
Hmm.
well, if you did that, like you said, if they did that, then what else are you doing that, could be suspect? And so, got to be really careful with that. And I think the big thing to our listeners, I just want to convey is, I love the our mid levels. I love our
Yes.
extenders. I love all of our clinicians, anyone who's a clinical person, because we need the help. We need you there. So this is not a discouraging, podcast. It's more, we want to make sure you have a heads up, that you are doing your due diligence, that making sure that when you hire somebody, they have a valid license.
Yes.
um, that if you decide that they're no longer with your practice, that you take yourself off as a supervising provider, otherwise it follows them with your
Hmm.
state, and that you check first in with your patient population, with your location, with what do you actually want them to do? Are you going to do care management services? Are you going to use them as an extender so that you can double your practice instead of bringing in another physician? Are they going to take call at the hospital? Does your hospital allow mid-levels to take calls? Sometimes they do, sometimes they don't.
Hmm.
So, and do you know your state rules? So, if you have anything to add to that, I think that's kind of where I want to wrap it up today.
Yeah, no, I think those are all, that's a great checklist, to do for people to just as you mentioned earlier, do your due diligence. They can be great for a practice, but you have to, just like with bringing on any employee, make sure that you can use them properly to where the practice is benefiting and the patients are benefiting the best.
Exactly. Well, Betty, I would like to thank you for being our guest on the podcast today.
Well, thank you. Thank you for having me again. I love talking with you about anything, anytime. So
Thank you.
I had fun.
We can always do this for hours, couldn't we?
Yes.
It's crazy. To find Betty and contact Betty, you can find her on LinkedIn or at our website at chcs.consulting. Also, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare regulatory update. Please go to nschbc.org and click on the tab Upcoming Education. We have a variety of topics for 2024 that you don't want to miss out on. Our next Medicare third quarter update is Tuesday, September 21st at 11 a.m. Eastern Time. I am the speaker for that. So again, go to nschbc.org to register. That's it for us today, folks. So make it a great day, make it a great rest of your month, and thank you for listening to the award-winning NSCHBC Edge podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.